Good morning and welcome to our Alaska Collaborative on Health and the Environment teleconference, Little Things Matter, Children's Health and the Impact of Low-Level Exposures to Toxins on the Developing Brain, with Dr. Bruce Lanphear. My name is Diana DeFazio, and on behalf of Alaska Community Action on Toxics, I'll be facilitating today's call. CHE-Alaska is a regional partnership group of the National Collaborative on Health and the Environment. CHE-Alaska aims to advance knowledge and effective action to address growing concerns about the links between human health and environmental factors. You can find more information at akaction.org and healthandenvironment.org. I sent a link to Dr. Lanphear's presentation an hour ago to everyone who signed up for the call, so if you haven't done so already, please take a moment to follow the link and download the presentation so you can follow along. Before introducing Dr. Lanphear, I wanted to mention that he presented yesterday on a CHE partnership call titled Lead's Long Shadow, What the Story of Flint, Michigan Means for All of Us. A recording of the call is available on the CHE National website, and I've included a link to it in the list of resources that I sent with the presentation link. And so now it's my honor to welcome and introduce our guest presenter for today. Dr. Bruce Lanphear is widely recognized for his work to mobilize environmental health research and actionable knowledge for health promotion and disease prevention to improve health of children around the world. Dr. Lanphear is a senior scientist and clinician at the Child and Family Research Institute, BC Children's Hospital, and professor in the Faculty of Health Sciences at Simon Fraser University in Vancouver, British Columbia. His primary research has been on quantifying and preventing the adverse consequences of low-level lead toxicity. The long-term goal of his research is to prevent common diseases and disabilities, such as asthma and ADHD in children. Dr. Lanphear has studied children's environmental health for nearly 2 decades and is currently principal investigator for the HOME study, a 400-person birth cohort study designed to examine the impact of low-level exposures to toxins on learning and behavioral problems in children. So a very warm welcome to you, Dr. Lanphear. You may go ahead and begin.
Thank you very much, Diana. I appreciate the opportunity to talk with you all. Hopefully next time maybe it could be in Alaska. What I would like to do this morning is provide a context on 2 things. One is why we should be more concerned about low-level toxins, particularly around brain development. And 2, I'd like to put it in the context of the broader narrative about what drives the way we make investments in our research and healthcare. So when I began my career 2 decades ago, I did it with the belief, the understanding that if I helped to identify important risk factors for disease, disability, or death, the science would be transformed into policy. Lives would be saved, people would be happy. But it isn't that easy. More often than not, we fail to act on important public health science. So I've spent the last 10 years trying to understand why. And I've come to believe that one of the most important reasons is that we're using an outdated story or narrative. So while I'll talk about the impact of toxins on brain development, or toxicants if you prefer, some people prefer that, I also want to do it in the context of how we are making investments and to begin a dialogue about how to shift that, if you agree, to a more preventive mode. Next slide. So why focus on brain development? Well, we're beginning to see, and have for the past 2 to 3 decades, that children today experience just a plethora of different brain disorders, brain-based disorders, from ADHD, which impacts about 1 in 10 children, to depression, about 1 in 15 children, conduct disorder, 1 in 50 children, autism growing rapidly, and now about 1 in 50 children or 60 children, and anxiety, which isn't as well mapped out, but we see it in many children. We don't know to a large extent whether these brain-based disorders are on the increase, but we certainly have clues, particularly around which has received a lot of attention in the past 2 decades. It's gone from about 1 in 5,000 children. Can you hear me okay?
I could hear you fine, but it felt like a word here or there was cutting out. Is there something going on your end?
Well, I'm at my mother's cottage, and the phone's doing something. Let's just keep trying, and maybe
yeah.
I'll be over.
It was working pretty well. Like I said, there was just a moment of cutout.
Fair enough. Excuse the interruption. So for autism, we've seen the prevalence increase from about 1 in 5,000 children in 1975 to 1 in 68 children in 2012. This slide, as you can see, is already outdated. It's hard to keep up with it. There's some evidence that ADHD is on the increase. That's primarily relied on parent report, which isn't as objective as other types of research, but there is some evidence that it's on the increase as well. So just to point out up front, while I'll be focusing primarily on environmental toxins, there are a number of factors that impact brain development, from the child's sex, whether they're male or female, to nutrition, preterm birth, social stressors, the built environment, maternal depression, genetic susceptibility, whether they attend preschool, and of course environmental toxins. It's also important to point out that many of these interact. So for example, with nutrition, if a child is iron deficient, they're going to absorb lead more readily. If the developing fetus is exposed to tobacco, even secondhand tobacco smoke, they may have less folate available. The mother may have less folate available to the child. So these can interact as well as each contribute separately. One of the things that I would like to point out, that why we can't take action, why we aren't willing to act on what we now know, is that we are entranced by technology. We've spent a vast fortune on what has been, with the exception of antibiotics and vaccines, a never-ending, ever-elusive search for cures. Yes, we have some miracle drugs like insulin, but there are few cures beyond antibiotics and some surgical interventions. Moreover, our fixation on technology fails to recognize or acknowledge that the pandemic of consumption, the worldwide epidemic of death and disability from chronic disease, is largely due to the innovative technologies of the past. Motor vehicles, tobacco, air pollution, unhealthy and heavily processed foods, and of course, environmental toxins. Let me give you an example of how we have made expenditures that really don't make sense. In the United States, in the first decade of this 21st century, we've spent over $1 billion trying to understand the etiology or the cause of autism, or autisms, if you will. There's more than one. We've spent $1 billion on trying to explore genetic risk factors, and 40 million, or 4%, on environmental ones. Now, if you think about a disease that has risen so rapidly in the past 2 to 3 decades, it can't be due to genetics alone. In fact, it primarily appears to be an environmental trigger with an underlying genetic susceptibility. So let me try to provide a little perspective on genes and environment. For too long still, we think of genes and environment, or nature and nurture, as two distinct boxes. A more appropriate way to think about it, particularly for complex diseases like, next slide. I'm sorry, I'm not doing good with the next slides. So we are on slide 8, and I'm talking about genes or environment with a red and blue and purple box. And we often think about genes and environment as separate, but it's a more apt illustration to think about autism, ADHD, depression, as well as cardiovascular disease, asthma, lung disease, as part of a complex interaction of genes and environment. Next slide. And what that means is that each of these diseases, the vast majority of diseases and disorders, are the interplay of genes and environment. Now, what makes that particularly appealing to me as an environmental health scientist, you can see on the next slide, slide 10, where Jeffrey Rose said, if causes can be removed, then susceptibility ceases to matter. Susceptibility, or genetics, ceases to matter. That is, all we have to do is take one of the two pieces of the puzzle out of the equation, remove the environmental risk factor, and we can prevent a disease or disorder. There's very little emphasis on prevention. There's more emphasis on treatment, and that's where genetics come in. Genetics can help us identify good treatments. In some cases, but not especially, it can also help point us towards prevention, We certainly don't hope that people will start to monkey with our genes to prevent a disease. That's fraught with all kinds of ethical dilemmas. Next slide. So with that as a context, I wanted to begin now to talk about environmental toxins. We'd like to think that our federal agencies are systematically screening environmental chemicals for toxicity, but the truth is that most toxins, most of the established toxins, were discovered only as a result of an environmental disaster, like what is depicted in this photo, Minamata disease, or congenital mercury poisoning. This photo helped to identify two misconceptions. First, that the placenta has a barrier to toxins. It doesn't. Second, as you can tell from the picture, the mother in this picture appears to be normal. But in fact, she was the one that ingested the mercury-contaminated fish. It's the daughter who was exposed in utero that was physically devastated, and we also know on average children who are exposed to mercury in utero have adverse consequences on brain development. But these environmental disasters, next slide, number 12, are just the tip of the iceberg. The vast majority of children whose brains are affected by toxins have subtle deficits or disorders that aren't seen until years after exposure began. Next slide. Why do we worry about the developing brain? The developing brain is more vulnerable than the adult brain. The blood-brain barrier isn't fully formed, and it's more permeable to toxins. Rapidly growing cells are often more vulnerable to toxins than slow-growing ones. This is the principle by which we treat cancer patients with chemotherapy. Chemotherapy is basically a group of poisons, and we treat people with cancer to try to kill the fast-growing cells. And it does preferentially kill the fast-growing cells. It also kills some of our healthy cells, and that's why we lose hair or have GI distress and diarrhea, because those cells are growing more rapidly. So by the same principle, when you expose the developing child, the developing brain, to toxins, that is going to be, those rapidly growing cells are going to be more vulnerable. Brain growth occurs over a longer duration than other organs, and during that growth phase, or the growth phase of any organs, they're more vulnerable to toxins. The fetus and child may lack enzymes that we use to detoxify contaminants. They just aren't mature yet. And finally, as most of you know, young children are often more heavily exposed to contaminants than older children and adults. They put a lot more of things into their mouths that aren't food, from house dust to paint chips to soil. And also, pound for pound, they ingest more water, juice, food, and other items. And if those are contaminated, they will get a bigger dose. Now, I hope that you were able to see the video. This next slide, slide 14, is just a blank slide. We haven't quite figured out the technology to share it this way. It's too big. But it is available, and I hope you've watched it. And I'll just very quickly emphasize the three things that that slide tries to convey. First, exposures not only to the established or suspected toxicants are ubiquitous. We're all exposed on a regular or daily basis, not only to those established toxins, but dozens, if not hundreds of other ones. There's increasing impact of low-level exposures to toxins on brain development, and I pointed to just a few in the video. Flame retardants called PCBs, organophosphate pesticides, and of course lead. Moreover, these toxins don't seem to exhibit a threshold or a safe level. They either seem to be linear, like with flame retardants and OP pesticides, or they appear even to proportionately cause more harm at the lowest levels of exposures, which seems counterintuitive. But in the video, what we try to show is that the first 10 microgram per deciliter increase in blood level in a group of kids is associated with about a 6 IQ point decrement. The second 10 microgram per deciliter, a 2 IQ point decrement. And the third 10 microgram per deciliter, a 1 IQ point decrement. So even though it cumulatively is worse to have a blood level of 20 or 30 than of 10, 6 of the 9 IQ points lost in that first 30 microgram per deciliter increase occurs in the first 10 microgram per deciliter. So what this suggests, next slide, slide 15, is that perhaps there aren't acceptable levels. And as I pointed out, we regulate chemicals and pollutants as though there are safe levels or there are thresholds, and that's with the exception of carcinogens. So let me give you a couple of examples that exhibit this same, what we call superlinear relationship, that is, steeper risks or steeper harms at the lowest levels of exposures. Next slide. First, looking at cardiovascular disease deaths by cigarette smoke or air pollution. This illustration works in either case. What you can see down at the lowest end, as the exposures to PM 2.5 increase, there's this very steep increase in the risk of death. And then it starts to plateau. That seems counterintuitive, but again, we've seen that now. There's at least 4 or 5 studies that demonstrate this in different cohorts around the world. It's very consistent. Another example, slide 17, shows as benzene exposure increases over cumulative part per million years, you see a steep increase at the low levels, and then again it plateaus. For benzene and leukemia, there might actually even be a mechanistic understanding of why that is. With benzene, it saturates the enzymes, and you don't continue to break it down. And it's the metabolites of benzene that are carcinogenic, that cause leukemia, not benzene itself. And so at some point, you stop producing these toxic metabolites because your enzymes can't break benzene down anymore. They're saturated. Another example, slide 18, you're all very familiar with the idea that women who smoke are more likely to give birth to babies who were born small. But what this slide shows that at the lowest levels of exposure, this study used cotinine, a metabolite of nicotine, as a biomarker, an indicator of exposure. It's at the lowest levels of exposures where you see this steep drop-off in birth weight. Almost unbelievable. Well, perhaps all 3 of these or 4 of these studies are unbelievable, but let me give you some evidence from Scotland, which helps to provide some validation of this low-level, exceedingly low-level impact on health. Next slide, slide 19, shows the impact of the ban on smoking in Scotland for non-smoking women, and that's important. What was the impact of banning smoking in public places on non-smoking pregnant women? There was a 15% reduction in preterm birth. 15%. Now, preterm birth in this case was defined as less than 37 weeks, born less than 37 weeks. When they looked at very preterm birth, that is born less than 34 weeks, there was a 25% reduction. This is better than any drugs out there. And yet somehow we still plod on thinking we're going to find that ever-elusive cure for preterm birth. And we ignore most of the evidence about toxins. What about lead in preterm birth? This was a study out of Bristol, England, where they found that women who had blood levels of 5 microgram per deciliter or higher were almost 2 times more likely to give birth to a child preterm. Next slide. This was a study that we did in the home study in Cincinnati birth cohort, and we found that a 10-fold increase in organophosphate pesticides was associated with a 150-gram reduction in birth weight and a half-week reduction in the duration of pregnancy. Now you might think about, well, those seem pretty minor, right? 150 grams, that's not much for a single child. A half week, most people can handle that. But here's the thing. Most pregnant women are exposed to a variety of environmental stressors and toxins simultaneously. So when we looked at the NHANES, the National Health and Nutrition Examination Survey, for another one of our videos on preterm birth, we found for just 3 toxins, women were simultaneously exposed to high levels of those 3 toxins which have been associated with preterm birth. So what we're talking about isn't one exposure to something like organophosphate pesticides. What we're talking about is cumulative exposure to a variety of toxins, each of which may contribute to a half-week reduction in birth weight, in duration in pregnancy. And the cumulative impact might be as much as 2 to 3 or even more weeks. And that may be what ultimately is the cause of preterm birth. And yet we soldier on trying to find that single, really, really big risk factor. But maybe there isn't one. The next slide, slide 24, introduces a concept called the prevention paradox. Now, the prevention paradox is a universal truth, although little known. And what it says is the majority of disease and disability occurs in those who are at low to moderate risk. Now, this sounds entirely counterintuitive, and I'll explain it in just a minute. But it's true unless there's a threshold, and it's true unless we define everybody as high risk. So let's use an example of lead. This is kind of a busy slide, slide 25. But as most of you probably are familiar with, the Centers for Disease Control in 2012 decided that there was no safe level of lead exposure. But because they recognized that we aren't willing to make investments to protect children, they didn't say it quite that way, they just said there's inadequate resources, they set the action level, they call it the reference level, or reference value, at 5 microgram per deciliter. That's the point at which we would intervene and try to identify environmental sources of lead for a child. About 500,000 children out of a 6-year birth cohort of U.S. children have a blood lead level of 5 microgram per deciliter or higher. And it makes some sense to target these children, to focus on these children, because on average, as you can see in the second column, each of those 500,000 children experience about a 6 IQ point decrement from lead exposure alone. That's a big deal. But collectively, if you take those 500,000 children and you multiply it by the 6 IQ points they lose on average, that only accounts for 3 million of the 23 million IQ points lost in that same 6-year birth cohort of kids. So we're failing to protect or preserve the vast majority of IQ points lost from lead exposure if we only focus on children who have a blood lead in excess of 5 microgram per deciliter. The second major flaw with this is that if a child has a blood lead level of 5 microgram per deciliter, most likely that's been built up over several months. And by the time we identify a child having a blood lead in excess of 5 microgram per deciliter, they will, on average, already experience some harm. So we really have failed to protect that child or those 500,000 children if they exceed 5 microgram per deciliter. So one of the real dilemmas that we need to think carefully about, and I think begin a dialogue about, is how much of our dollars do we invest in high-risk strategies and how much in low-risk strategies? This is slide 26. I'm certainly not suggesting that we ignore children who have elevated blood lead levels or people who are sick. But the point is, until we start focusing on the whole population, we will fail to prevent disease. It's inevitable. So one of the promises that I think all of us were made, whether we're aware of it or not, next slide, slide 27, is that if the science provides evidence about what causes harm, and if it's cost beneficial, then we will act to protect people, to protect public health. Well, it's not true. Sorry. This was a study done in 2009 by Elise Gould, and what she found was that for every dollar we invest to protect kids from residential lead hazards, as a society, we would benefit somewhere from a low of $17 and a high of $220. That's an extraordinary cost-benefit ratio. Most of us are familiar with the often touted cost-benefit ratio for childhood vaccines. Next slide, slide 28. I usually, at this point, ask the audience, what do you think the cost-benefit ratio is for childhood vaccines? But that's a little hard today, so I'll just move right ahead and show the answer. For every dollar we invest in childhood vaccines in a country like the United States, as a society, we benefit about $16.5. That's really quite extraordinary. And what I just showed you is that lead is at least as cost beneficial, if not extraordinarily more so, than childhood vaccines. Now, I'm not trying to suggest that childhood vaccines aren't important. What I am trying to suggest is that the brain is as important as cancer, and yet we spend trivial amounts protecting children's brains and the brains of the rest of us compared to trying to find a cure for cancer. We've just invested another $1 billion in the cure for cancer. This is the 4th decade of that war on cancer, and there's very little cures to show for it. That doesn't mean we shouldn't keep trying, but it does suggest perhaps we should be thinking more about prevention, because we know a lot about how to prevent cancer, and yet we do very little to do it. What about other kinds of interventions? This is a slide that shows cost-saving preventive interventions, and let me just kind of walk through it because I'm not sure it's intuitive. There's different kinds of preventive interventions. There's those that occur at the individual level, non-clinical, person-directed. There are those that are clinical, which happen between a nurse or a physician and a patient. And there are those that happen at the population level, or environmental interventions. 46% of environmental or population interventions are cost savings. Only about 15% of individual or clinical interventions are cost savings. So once again, it begs this question: why aren't we making more investments in prevention and population level interventions? Is it only simply because people haven't figured out how to privatize the benefits, how to profit from it? Is it that simple? We are, next slide, slide 31, experiencing a pandemic of consumption. Over the past 10 years, I've become increasingly vexed by our inability to control the pandemic of consumption, the largely preventable worldwide epidemic of chronic disease and disability due to industrial pollutants, environmental contaminants, and excess consumption. While it's easy to blame industry, and they deserve most of it, I have come to believe that the conclusion that the story or beliefs that drive medicine and public health is broken. It's obsolete. We are, it seems, on a never-ending search for the ever-elusive cures for chronic disease. But with the exception of antibiotics, there are few. Yet we invest over 95% of our health dollars on treatment, and the vast majority of our research dollars seeking cures. We spend vast fortunes on innovative technologies, even though much of the disease, disability, and death are due to the innovative technologies of yesterday. Meanwhile, we ignore or minimize compelling evidence that environmental toxins are major risk factors for disease, disability, and death. Next slide, slide 32. Isn't it time to give prevention a chance? What is our ultimate goal? To find the cause or cure, to prevent disease or treat it? I, for one, would prefer that my children never have a disease or disability in the first place. And I think most parents would agree if offered the choice. Well, flipping back a little bit to environmental toxins, what are some of the lessons we can take from the FDA? I don't know if many of you recognize the young child in the lower right corner. We're on slide 33. This is a child that had phocomelia, or seal limb, from exposures to thalidomide. In the left image, you can see President JFK giving Francis Kelsey, a Canadian who's still alive and over 100 years now, who refused to approve thalidomide as a FDA bureaucrat. It was approved much earlier in Canada and Europe, and they experienced much higher epidemic of thalidomide-induced disorders. 5 decades before the thalidomide epidemic occurred, there was a couple handfuls of what used to be called progressives, people who fought for regulations on drugs, knowing full well that there were people dying because up until the thalidomide epidemic, drugs were not required to be tested for safety or efficacy before they were marketed. Next slide, slide 34. We all would like to think that there are laboratories in Washington, D.C. or Ottawa or even our state governments that are thoroughly testing the safety or toxicity of chemicals before they're put on the market. But it's not true. These aren't rodents in those labs. Those are our children. Those are our pregnant women who are being exposed to chemicals that are, for the most part, largely untested before they're put on the market. Now, we can hope that TSCA reform that's ongoing this year is substantial. I wouldn't count on it unless we're willing to stand up and demand it. Industry has gotten their fingers into it yet again and weakened it, watered it down. It may provide some benefits, but it's not going to get us where we need to go unless it changes dramatically. So at this point, what I'd like to do is just take a few minutes to talk about, well, what can we do about it? When I first started to do a talk like this, 5 or 6 years ago, I would often get a parent or a nurse or somebody would come up afterwards and say, okay, so you scared the hell out of us. What do we do about it? Next slide, slide 35. The first rule of thumb, if we didn't evolve with it, avoid it. Now that needs a little caveats. Lead has been around forever. It's an element, but our ancestors weren't exposed to it in high concentrations until we began refining it during the Roman period and especially during the industrial era where the levels of exposure increased thousands of fold. So if we didn't evolve with it, avoid it. If you're not convinced it provides benefit, don't use it. Next slide, slide 36. How to avoid exposures to toxins? Eat fresh, organic, and unpackaged foods if possible. Avoid canned foods. Now this may seem challenging. In some cases, the cost, of course, can be more than conventional foods. But I think we've also been lured into thinking that our food should be cheap or inexpensive. Not only does that mean right now that we're ingesting toxins, it also means that the frontline workers are getting paid very little for their livelihoods. And so I think we might want to rethink how much we're willing to spend on foods. Minimize the use of pesticides around the home. Pesticides have been associated with two things of consequence to children. First, impacts on brain development like IQ deficits. And second, the development of childhood leukemia. In fact, perhaps an example of how we failed to emphasize prevention is that we spend the vast majority of our resources dedicated to cancer on treatment, raising money for more treatment, and yet there's at least 4 well-defined risk factors for the development of childhood leukemia: proximity to highway, paint and solvent exposure, pesticide exposure, and tobacco smoke exposure. We haven't been able yet to quantify whether that accounts for 10% or 50% of new cases of childhood leukemia, but still the point is we failed to take action when we know what some of the risk factors are for one of the more serious diseases of childhood. Avoid cosmetics, fingernail polish, and lotions. I tried for years with my 3 children, all daughters, to get them to avoid cosmetics, fingernail polish, and lotions, only with minimal success. I was able to help purchase less toxic products, but our daughters in particular are convinced through all the marketing that if they don't use these products, they won't be beautiful. And I try so hard to tell them that they're beautiful just like they are, and as you might know if you're a parent, I've not been very successful. We have new threats, not bears and lions and tigers, but marketing that we have to deal with before we can encourage our children to be independent. They prey upon our children. Support bans on smoking in public places and cosmetic pesticide use. We have in 5 provinces around Canada banned cosmetic pesticide use. Some of you may have recently heard about the success in Irvine, California. The Parents Against Toxics in Irvine we're able to work with City Council to ban pesticide use in parks and playgrounds around and schools around the community, and others are working on the same. They're unnecessary, they're expensive, they're poisons. Support efforts to update chemical management policies and reduce industrial pollutants. In the end, this is perhaps the most important thing that we can do. We shouldn't and can't expect parents to solve these problems on their own. One of the most telling illustrations of this occurred when I was being interviewed for a book by Joel Bakken. And I was going through this litany of different toxins and what they cause, and after about 5 or 10 minutes, Joel stopped me and he says, wait a minute, stop. You do this for a living, right? I said, yes. You have children? I said, yes. Can you protect your own children? No way, I said. Why should we expect any parent to be able to protect their kids if somebody who does this for a living can't? Next slide. We also have to push back against some of these, let's call it propaganda or marketing if you prefer, these beliefs that we can't feed the world if we don't use pesticides and synthetic fertilizers. New evidence from systematic reviews shows that's just not true. It really is a problem of resource distribution, not using or not using pesticides. And so we need to be skeptical of some of these messages that we've believed for so long, that we've taken for granted. And finally, the last slide, slide 38. We have, for the past 50 or more years, lived out of a story that with enough investment, we will find cures for what ails us or kills us. This story, which worked well for infectious disease, gave us a sense of comfort in the face of death and disability of uncertain etiology. But the never-ending, ever-elusive search for cures for chronic disease has largely been a failure. The few successes, like the declines in lung cancer, have largely been the result of efforts to prevent disease. We know enough to prevent a lot of death, disease, and disability, but for the most part, we don't. It won't be easy, but if we want to make a difference in our children's lives, it's time to revise our story and give prevention a chance. Thank you.
Thank you so much, Dr. Lanphear, for your thought-provoking presentation, and I suspect we will have a lively discussion. So at this time, I would like to open the lines up and invite participants to ask questions and make comments. Just before I do that, though, I should just say we did send around a link to the Little Things Matter video, which is what Dr. Lanphear was referring to on that blank slide. It's a 7-minute video, and you all have that link, so if you didn't get a chance to view it before the presentation began, you can do so later. So again, if you'd like to participate in our discussion, please press *2 to unmute your line and state your name and affiliation, and we're ready to start. I just want to confirm that people could hear me. Dr. Lanphear, can you just confirm that my announcement? Okay, I just want to make sure when it's that quiet on the other end. Again, *2 to unmute your line if you'd like to ask a question or make a comment. And I do see a few lines unmuted, so somebody just jump right on in.
Okay, I'll
jump. Oh, go ahead.
I'm Tiffany, and I'm wondering, with all the research that's been done on autism, what are the conclusions that all this money has given us?
Well, as I said, Tiffany, most of the research dollars have been spent on genetics, and so out of all of those, 2 conclusions can be drawn by themselves. Genes may account for 15% or less of autism. But I think that probably underestimates it because, like other complex diseases, you have to be susceptible. You have to be genetically susceptible in order for an environment to trigger a disease. So I think the best way to think about it is that in the end, about 50% of autism will be found to be genetic and 50% environment. or 100% environment and 100% genetic, if that helps, because you need both. I guess that's the main point. What we have learned...
Well, my question is, with that incredible rise that you showed on your slide,
yeah,
genes haven't changed that quickly, so it seems to be that it's something environmental.
I agree.
And so, I mean, are we thinking it's EMF? Are we thinking it's vaccines? I mean, I know you're focusing on the toxins and the heavy metals, especially, and pesticides. I mean, and there's a whole soup. But does the research help us at all to understand this? What's going on?
Yes. So three things have sort of risen to the surface on the research environmental research that's been done so far. About a dozen studies have looked at air pollution. Most of them have found not always the same pollutant, but that air pollution or proximity to highway traffic seems to be a risk factor. Folate also seems to be a risk factor, which is kind of odd because this increase has happened in the midst of supplementing folate in our diets. But if you have insufficient folate, that seems to be a risk factor for the development of during pregnancy. And the air pollution exposure has also been exposures during pregnancy. The third one that seems to be playing out a little bit, there's one or two signals from different chemicals as well as pesticides in particular, pesticide exposure. So one of the things that I'd suggest the way we think about autism, which is very much like ADHD, is that these conditions aren't a single well-defined entity. Rather, they're more like a medley of maladaptive behaviors. So one child with autism may have these 10 symptoms and 4 deficits, and another one might have these 8 symptoms and 2 deficits. And the way you get those symptoms or the way you develop those deficits may come through different ways. It may be that, for example, with ADHD, lead increases aggressive and externalizing behaviors, and then on top of that, tobacco increases the inattention. But collectively, it's the cumulative exposures to 3 or 4 different things, as well as the underlying genetic susceptibility, that ultimately creates an epidemic like ADHD or autism.
Thank you.
You're welcome.
This is Gillian Middlestick. Can you hear me?
Yes, I can.
Great. Hi. First, I just wanted to say thank you, Dr. Lanphear, for your work, and thanks to ACAP for putting this on. My question is, and I'm sorry, I'll back up. I represent the Tribal Healthy Homes Network. Here's my question. I was doing a lobby day in D.C. 2 weeks ago on healthy homes, and the challenge was learning that $21 billion was spent in 2015 alone by the pharmaceutical industry on respiratory drugs. So primary prevention, while it shows all that ROI, is where do we begin if we have an entire industry that gains enormous profit off secondary and tertiary prevention? Okay. I know it's a complex question, but I'm finding it, and I don't want to demonize them, but it's quite a barrier. So curious about your thoughts.
Yeah, I agree, Joanne.
Dr. Lanphear, right before you respond, I just want to say there's quite a bit of background noise. I know about 10 people have unmuted their lines to ask a question. You might want to just mute it again, and then unmute right when you're ready, when this answer wraps up, because it's just getting a little bit loud and hard to understand in the background. Okay, right. Sorry.
Okay. Yep, no worries. So, Joanne, I've experienced the same worry and concern, and this was one of the reasons about 10 years ago I started to shift my effort to try to find ways to translate the evidence so that the broader public had access to it. I'm not doing a very good job, but I'm doing my best, and that was one of the reasons we started to work on the videos. I think the only way we can overcome the tremendous lobbying efforts of the pharmaceutical industry and other industries, the genetic industry, and even the medical industrial complex and the research industrial complex where, in the universities I've worked, is that there's so much focus on clinical revenue, on bringing in new grants. we've got to find ways to combat that. And I think in the end, I've talked to Congress. You obviously have as well. That by itself, we know, isn't enough. I think the only way that we're ultimately going to bring about change is if we get enough of the public, and probably it's really moms, who stand up and say, enough. Enough, quit damaging our kids. Now, that may sound strange coming from a university professor, but that's my conclusion. And it's got to be enough because it's got to overcome all the industries that I've just talked about, including all the vested interests. And everybody's out there for getting a piece of the pie. And until we stand up and say what we want is to protect our kids, and it'll need to be millions of people, tens of millions of people. I don't see, and I suppose the other thing to recognize in the wake of the Flint tragedy, it will take a series of crises like Flint before we really deal with this problem.
Yep, that's a great answer. Thank you. And I would say sick people are a really profitable industry in Western countries, so it's a tough issue to build a constituency. But thanks for your answer. I appreciate that.
You're welcome.
Thank you. We have still about 10 minutes left for discussion, but I do ask that you make your questions relatively brief, just so that we have a chance to get to a number of you.
Yeah, hi there. This is, can you hear me?
Yes.
Yeah, hi. This is Ali Hamadi from the Alaska Division of Public Health. We appreciate the message on prevention and the need to explore further the low-level exposures to environmental contaminants. We fully agree with that. I just felt that one of the slides might need some qualifications, especially the one with the mom holding the child, and that's from Minamata Bay exposures. I just want to say that that child was likely, just what we know from Minamata, the mom was exposed to mercury levels that are higher than anything that we've seen with our cohort. Over 2,000 people, mostly women of childbearing age in Alaska, have been exposed to mercury. So I would just want to qualify that, yeah, we could be exposed to mercury, and mercury is a really bad player. I really would like to minimize my exposure. But when we get it from fish and other traditional foods, we're getting so many other benefits with it, and in the vast majority of cases, those benefits outweigh the risks. And to speak to that, many studies have shown that moms who consumed more fish during pregnancy, up to a certain level, had children with higher IQs than women who consumed less fish. I just want to make that clear from our perspective, because we value traditional foods and the benefits that the Alaska population gets from. And thank you.
You bet, and thank you, Ali. It's a good point to make, and gets at this issue that oftentimes becomes quite controversial: high versus low exposures, for example. And how do you think about something like fish intake when we know it's beneficial? What I would add to your comments, and not in any way to detract from them, is to say I agree, but I would also point out two things. First, the second child my wife evaluated, she's a developmental pediatrician, when we moved to Vancouver, was a child who had severe motor coordination, she was clumsy, and she had she drooled a lot. Going back into her records, it was clear she had congenital mercury poisoning. Some experts think it did not happen outside of Japan. It does. Second thing, yes, it makes sense to encourage people to eat fish. Where I think we failed as a public health community is that, and global governance, is all the while we're asking women to eat different fish, we are not reducing levels of pollution in the environment. We've seen 3% increases in the past 3 to 4 decades of mercury in Pacific fish. Now, there is a new treaty, the Minamata Treaty. We can have some hope, but what I think is terribly unfortunate, troubling, is that for too often our public health messages are, oh, high ozone, don't go outside and play, Johnny. Oh, mercury contaminated fish, Don't eat that kind of fish, Mom. And that's as far as the message goes. The message is put on, the burden is put on the consumer to solve these public health tragedies, crises, that are put in place by the industry, and we're failing to hold them accountable. So I don't disagree. In fact, I agree with every point you made. But the bigger picture is, because we have diminished the role of public health, we are failing to protect public health, and we're failing to hold industries accountable.
Thank you. Yeah,
Thank you.
We agree that we need to reduce contaminant levels as much as possible.
Thank you.
Hello, this is Susan Kanan, fluoride-free Alaska here in Anchorage, and we're trying to get the fluoride turned off here in the water, and fluoride is known to be a neurotoxin, and I was hoping Dr. Lanphear can address that issue. And our exposure to fluorides are totally increasing with phosphate fertilizer, with the infant formula, with liquid fluoridated, reconstituted with fluoridated water. Can you address the issue of excess fluoride exposure to our children?
Yeah, you guys aren't giving me the easy questions, are you? Fluoride is a fascinating controversy. I think, like you, Susan, I share concerns that the types of studies that should have been done to determine whether fluoride exposure is safe or toxic have not yet been done, and yet it is our waters are being fluoridated around the world. About 75% of water supplies in the United States are fluoridated, 50% in Canada, only 3% in Europe. Why should we be worried? Well, there's the cross-sectional studies that you've alluded to, Susan, mostly out of China, mostly at higher levels, but what they suggest is that there's a difference as much as 7 IQ points in fluoridated versus non-fluoridated communities, with fluoride being a possible neurotoxin. A couple things we need to think carefully about. First, the studies showing that fluoride protects against caries are pretty weak. They're ecologic and cross-sectional for the most part, but so are the studies showing that fluoride is toxic. I think we'll see in the next year or two some prospective studies that provide some additional information that will help us make a decision. In the meantime, there's other questions. What's the quote optimal dose? And even with that quote optimal dose, there are children who are fed formula that are getting much more than the optimal dose because they're getting so much of their food, their intake from fluoridated tap water. The other thing that raises questions is, does the ingested fluoride really protect against caries, or is it only the topical? Finally, in the province I live, British Columbia, we don't fluoridate the water. And in some of the communities that don't fluoridate, we don't see big differences in the rates of tooth decay compared to those that do fluoridate. So there's a number of questions that really need to be addressed. And I think the most important thing is we should no longer push this under the carpet. We need to take it head on. We need to do studies. We need to get people, the public, a chance to be involved as that evidence emerged and make decisions on their own for their own communities.
Thank you. I think we have time for one or possibly two more questions or comments.
Okay, I have a question. This is Dr. Fran Solomon from the Evergreen State College in Tacoma, Washington. So thank you, Dr. Lanphear, for your excellent presentation. So you mentioned that children with iron deficiency absorb lead more rapidly than children with normal levels of iron. So would you explain the mechanism or why that's the case?
Yes. In a simple way, we know that if you have iron deficient children or calcium deficient children, they will absorb lead more readily. And it may be simply that they all share, they're all divalent cations, they share that 2+ charge. But we know that it actively transported using some of the same mechanisms in the gut. And that's why we think it's a particular problem. that iron deficiency is a particular problem. The kids simply absorb more, or calcium deficiency. They simply absorb more, trying to make up for those deficiencies by absorbing other divalent cations, and lead, if lead's in the environment, will be pulled in to a greater extent. Other things like if a child is fasting, if they haven't eaten in many hours, or if an adult for that matter, they will absorb more. If the lead is ingested with an acid like orange juice, you can also absorb more. So those are some things we can try to do. The one thing I would say about nutrition, oftentimes we do recommend supplements with calcium or iron for children who are lead poisoned, or women who have high blood levels for that matter. And it makes some sense, but at best it will probably reduce absorption or reduce blood levels by 15 or 20%. It's not the solution. The only final solution, which we know to be true in public health in general, is to reduce the source.
Right. Okay.
Thank you. Could I ask that anyone who's already asked a question be sure to press *2 to mute their line? It'll help me see how many questions are out there still. And Dr. Lanphear, are you able to stay like 3 or 4 minutes over the time, or do you need to stop? Okay. So I think we can take a few more questions.
Hi, this is Michelle Lee in New York with Council on Intelligent Energy and Conservation Policy. And I'm groups I work with, including some UN NGOs, are desperately trying to start bringing the same approach to the energy realm. And I thought it might be of interest to know that in Japan, following Fukushima, it's almost like a national war there now between the moms and the industry. So I was very taken by what your point was, that we really have to reach the moms, because that's who is standing up in Japan and fighting the nuclear industry in Japan. I would just add one thought. I think the more we can educate the public, particularly educators, about the mechanisms, the underlying mechanisms that are creating these problems, that the more we'll be able to communicate the issue of the effects of toxins, because the focus is so much on what standard of what dose is allowable and what specific chemical has been investigated by what specific group and how many people were in the cohort and all that stuff. And it becomes an impossible task ultimately because of the complexity. But if you start focusing more on what the actual cellular mechanisms are, epigenetic mechanisms, genetic, and so forth, and particularly the brain, that's a way to really sort of reach people. They sort of get it.
Well, I tend to agree with your description of the problem, but I have a slightly different perspective on the solution. I think that the pattern of toxicity that we've seen is sufficient that we need to just radically change the regulatory system about how we evaluate chemicals before they're put on the market. I don't think necessarily understanding the mechanism is going to solve our problem. This has been what we've been pushed to do, that, well, we can't ask industry to stop selling their product until we know the mechanism by which tobacco causes lung cancer. We can't ask the paint industry to stop using lead until we know the mechanism. Does it really cause this, or is it confounding? I think over the past 2 to 3 decades, the whole narrative has shifted to the point that we can no longer ignore the fact that low-level exposures to chemicals can cause damage, big-time public health damage. We know that to be true, just like we discovered it with thalidomide and other drugs in the first half of the 1900s. So to me, the solution is not to go deeper and deeper and deeper into the research, although of course we should. The solution is to step back and say, should we be exposing kids to chemicals of unknown toxicity? Should we be exposing pregnant women? We know they have the potential to be toxic. To me, that's the solution, to change the regulatory system. In terms of the public health, I think we need to change the narrative to recognize that the goal is not to treat disease. The goal is to prevent it. And so to me, it's a narrative that happens before we start thinking about mechanism.
Well, I didn't mean to say that the mechanism was the way to go from a point of view of requiring more regulation. I was simply saying that, I mean, I know when I've talked to people at the EPA, and I focus in the nuclear, opposition to nuclear realm, that very, very high-level officials at the EPA are utterly unaware of the vast, many, many different ways that radionuclides can impact biological beings. Their focus is like almost exclusively on cancer, and that mindset has made them not think of the overall public health crisis, with such as developmental disorders, autoimmune diseases, and that kind of thing.
Right. But of course, the EPA, they're part of the obsolete story or narrative, and we need to change their narrative as well.
I think we have time for just one more question, and then we'll need to wrap up. So if there's anyone that has a burning question that they'd like to ask of Dr. Lanphear or a comment to make, please step forward. Star 2 to unmute. Okay, then.
Oh, this is Kristen Cox. Can you hear me?
Yes.
Yep.
So I'd just like to make a quick comment, which is that Alaska is one of 16 states that doesn't have a smoke-free workplaces bill to protect people from secondhand smoke in the workplace. There is Senate Bill 1 has been sitting in Senate Finance since April. So, and we're getting a lot of opposition from the e-cigarette industry, which thinks that a secondhand aerosol is not toxic to people. So just so everybody knows that.
Yeah, and I think one of the big questions, even though I think most people in public health would say, if you have somebody who's smoking tobacco, it would be better to shift them to e-cigs. There's still some concerns about the toxicity of nicotine and cotinine on the developing fetus, on the developing brain in particular. And so we need to be cautious about exposures that may happen to pregnant women. And as the study from Scotland shows, even little bits matter.
Okay, well, I think that's a good place to end. And again, Dr. Lanphear, we'd really like to thank you for your time this morning and your very compelling presentation. I want to remind everyone that a recording will be available of this call. And yeah, we appreciate all of you joining our call today and the participation. So thank you all once again. Dr. Lanphear, is there any final comments you'd like to make, or did you cover most all that you wanted to on this call?
Well, first, just to thank you all for listening, and then stand up.
Thank you. So a great call to action, and in our follow-up, we will also be sending you information about how you can act locally in Alaska and nationally to change chemical laws. So thank you all very much once again, and have a wonderful day.
Thank you.
Thank you.